In this video, we'll discuss about respiratory syncytial virus. It is belong to Paramyxoviridae family. Paramyxoviridae family, single stranded RNA containing enveloped virus. This respiratory syncytial virus RSV first isolated from chimpanzee with coryza. First isolated from chimpanzee with coryza. Respiratory symptoms found in chimpanzee. So it is called as chimpanzee coryza agent CCA. This RSV first isolated chimpanzee with coryza. So it was called chimpanzee coryza agent. It found that symptoms in chimpanzee, respiratory symptoms in chimpanzee. After 1 year, this virus is obtained from children with lower respiratory tract infection. After 1 year, the virus is obtained from children with lower respiratory tract infection, where it caused cell fusion and formation of multinucleated syncytial in the cell culture. Multinucleated syncytia in cell culture. So it is called, so that reason only it was called respiratory syncytial virus. First isolated chimpanzee with coryza, so it have that name CCA. After 1 year, the virus first isolated from children with lower respiratory tract. So it have that name. So where caused cell fusion and the formation of multinucleated syncytia in the cell culture. So it have that name respiratory syncytial virus. So RSV is most important cause of lower respiratory tract infection in infant. So it was the important cause of lower respiratory tract infection in infant. Coming to morphology, pleomorphic and the viral envelope is made up of two glycoprotein. It is a pleomorphic in nature. Viral envelope is made up of glycoprotein, two different type of glycoprotein. One is G protein, another one is F protein. The G protein, it is responsible for providing attachment of virus to the host cell surface. So what is the role? It is responsible for providing attachment of virus to host cell surface. F protein, a fusion between viral and host cell membrane, and also responsible to cell fusion. So cell to cell fusion, it is responsible for this one, sensational cytopathic changes. So another things responsible for sensational cytopathic changes. One more important things, no heme agglutinin activity. So no heme agglutinin activity in RSV, respiratory syncytial virus. This characteristic, that means no heme agglutinin activity. This characteristic differ from other paramyxovirus. This virus only no heme agglutinin activity, and another property, no neuraminidase or hemolytic properties. So no neuraminidase or hemolytic property in RSV. There is only one antigenic virus type two. It have two subtype A and B. So here what are the characteristic? No heme agglutinin activity. This character only differ from other paramyxovirus. Then no neuraminidase enzyme or hemolytic property. Now coming to clinical features, most of RSV infection are symptomatic. Infection, respiratory illness in infant, febrile rhinorrhea, febrile rhinorrhea with cough and wheezing in children, in infant, febrile rhinorrhea with cough and wheezing. This one progresses 25 to 40% of cases. This disease progress to lower respiratory tract involvement like tracheobronchitis and bronchiolitis. Tracheobronchitis and bronchiolitis. This one, about 1% of that infection becomes serious. 1% of infection becomes serious. Required hospitalization. Recovery from RSV infection most commonly by 1 to 2 weeks. But in immunodeficient patient, or immunodeficient patient with the cardiac affect, there is protracted illness with high death rate. 1% cases only serious required hospitalization. Recovery these from RSV 1 to 2 weeks. But immunodeficient or heart defected patient means chances for high death rate. RSV is an important cause of otitis media, that is middle ear infection. Otitis media in young children. In adult RSV infection, presence of febrile common, and elderly it is causes pneumonia can occur. So young children otitis media, adult febrile is common, then early patient pneumonia can occur. Next one is epidemiology. RSV, it is a global in distribution. Infection is most common in children between 6 to 6 months of age. Peak in 2 to 3 months of age. Because before 2 months, that newborn are protected by maternal antibodies. So this one global distribution, most common 6 week to 6 month, peak 2 to 3 months. First 2 month newborn not affected because of maternal antibodies. Then transmission, close contact, contaminated fingers and vomits. The coarse tablet of respiratory secretion when coughing and sneezing are more efficient transmit infection than fine aerosols. So close contact, contaminated fingers and vomits, respiratory secretion, coughing, sneezing. This one reinfection is very common in RSV, but that reinfection very severe than primary infection, very severe than primary infection. Subsequent infection very mild. The secretory immunoglobulin A more important than circulating IgG in production. The recovery from infection, cell mediated immunity, plays a major role than humoral immunity. So recovery cell mediated immunity is more important. Recovery from cell mediated immunity play a major role and comparing to humoral immunity. Next, laboratory diagnosis, collection of specimen, nasopharyngeal swab or nasal washing. Second is virus isolation. Here the samples are inoculated into cell culture. Most commonly used HeLa or Hep2 cell line. The inoculation is performed immediately after collection because the freezing of sample may destroy the virus. So here after sample collection immediately we will do inoculation, otherwise the freezing sample may destroy that virus. Then cell culture characteristic gained cell and syncytial formation. Then cytopathic effect takes about 10 days to appear. So early detection of virus growth by immunofluorescence, which very rapid. Immunofluorescence technique is rapid. Then serological technique done by demonstration of rising antibodies titer in paired serum samples. Serology is performed by ELISA, complement fixation, neutralization, or immunofluorescence. So serological here antibody titer value will increase. Here what are the technique we are using? ELISA, complement fixation, neutralization and immunofluorescence. Then molecular method we are using reverse transcriptase polymerase chain reaction. This reverse transcriptase PCR which is sensitive and rapid. Then prophylaxis and treatment, no effective vaccine available. So treatment purpose, primary management, rifavirin they used. This one will decrease that illness and decrease the duration of virus shedding. So treatment purpose using rifavirin. Respiratory syncytial virus infection, paramyxovirus family, obtained children lower respiratory tract infection. Two type of glycoprotein G and F. Laboratory collection, diagnosis, sample collection, virus isolation, cell culture detection, serology, molecular method, prophylaxis, and finally treatment. Thanks for watching.